Hi, I'm Penny Feldman. I'm the pediatric endocrinologist at the UMass Duchenne Muscular Dystrophy Center. And it's been wonderful working with the team at the center and meeting many of the families there. So my presentation is on endocrine disorders caused by chronic steroid treatment for Duchenne muscular dystrophy. There are no conflicts of interest to disclose. The objectives are that you'll learn about endocrine disorders due to chronic steroid treatment, adrenal insufficiency, osteoporosis, weight gain, poor growth, and delayed puberty, and also understand treatment options for these endocrine disorders. So Duchenne muscular dystrophy is caused by absent or very low levels of dystrophin that causes inflammation in the muscle. And this is treated with steroids such as deflazacort, Emflaza, and prednisone. So first I will discuss adrenal insufficiency. The adrenal glands are small glands that sit on top of each kidney, and they're regulated by glands in the brain, and these glands are called the hypothalamus and the pituitary gland. And they stimulate the adrenal gland to make a hormone called cortisol. Cortisol is an important hormone for metabolism, maintaining water and salt balance, maintaining blood pressure, and it's also a stress hormone. So when somebody is ill or has a significant trauma or is undergoing surgery, the adrenal glands increase the amount of cortisol that's produced. Cortisol is in the same class as the previously mentioned steroids, which I'll refer to as prescribed steroids that are used to treat boys with Duchenne muscular dystrophy. The difference between those steroids and cortisol is that those steroids are 3 to 4 times stronger than cortisol. So what happens is that boys who are on these steroids chronically, it shuts down this whole axis so that their adrenal glands no longer make cortisol. But as I had mentioned, the prescribed steroids are much stronger than cortisol. So as long as they're taking the prescribed steroids daily, they have enough of the steroid for their daily needs. Plus, they also have enough of the steroid to cover them for stress situations such as a mild or moderate illness. The concern arises with adrenal insufficiency if the daily prescribed steroid is missed. And then some symptoms of adrenal insufficiency can develop. And as you can see, some of these symptoms, such as nausea, vomiting, abdominal pain, are really very nonspecific symptoms. And the concern is that it may be attributed to something else and not to the adrenal gland. With worsening adrenal insufficiency, someone can have difficulty maintaining blood pressure, they can become confused, and it can be a potentially life-threatening situation that can result in death. So what we do is we have a backup plan, and the backup plan is an injectable form of the steroid, and it's called Solucortef. And families are taught how to administer this in the clinic, and they have a prescription for it at home. So if a situation arises and the child vomits the prescribed steroid and cannot take it, then this medication can be given. Another scenario that sometimes arises that somebody needs to have surgery done, and the families are told not to give their medications prior to the surgery. So this is a medication that can be given intravenous prior to the surgery. Next, I will discuss osteoporosis. So sex hormones, such as testosterone, are important for bone mineralization. The prescribed steroids frequently cause delayed puberty, so the boys don't go into puberty, so there's no testosterone around. The prescribed steroids also decrease vitamin D and calcium absorption from the gut. They also increase the excretion of calcium from the kidneys. The prescribed steroids also inhibit bone-forming cells and increase the bone-resorbing cells. The bone-resorbing cells are the cells that cause bone breakdown. And all of this is a setup for decreased bone mineral density and osteoporosis. This is a bone DEXA machine that can measure bone mineral density, and it's measured it's measured for the spine and for the distal portion of the long bone of the leg called the femur. Other tests that are done is an X-ray of the spine, because compression fractures, which is fractures of the spine, are very common. And sometimes these fractures may be asymptomatic, so the child may not be complaining of any pain, so it can be picked up on the X-ray. Other things that are monitored is blood work for calcium, phosphorus, and vitamin D levels. This X-ray here shows a normal spine, and you can see each of the bones of the spine, how they're the rectangular shape. Over here is an example of a compression fracture, and you see the loss of height. So treatment involves optimizing calcium and vitamin D intake through diet and supplements. And as Dr. Wong had previously mentioned, we tend to be very proactive with bone health. And when we see that bone mineral density is not increasing, we recommend medications. And so bisphosphonates are a class of medications that inhibit those bone-resorbing cells. Alendronate is a medication that's given as a tablet form, that's given orally, and it's best taken on an empty stomach, 30 minutes before eating, and drinking plenty of water to prevent some of the side effects. With more severe osteoporosis and fractures, an intravenous form of the bisphosphonate is used, and that's called zoledronic acid. And that's administered typically at 6-month intervals. Common side effects are flu-like illness, and it can cause low blood calcium and phosphorus levels. So we make sure that vitamin D and calcium intake is optimal and levels are optimal prior to the infusions. Next, I will discuss weight gain. So the prescribed steroids are known to increase appetite and increase weight. And you can see here this facial fullness due to the weight gain. Other places where you get the weight gain is at the nape of the neck, and then you can also see the increase in weight gain in a truncal distribution. Prednisone is known to have more salt-retaining properties than deflazacort and Emflaza. We also see insulin resistance due to the steroids and increased triglyceride and LDL cholesterol. So the prescribed steroids act on the liver to increase the glucose or sugar output and decrease the uptake of sugar by the liver and the muscle. And this is due to what we refer to as insulin resistance. Insulin is the hormone that helps bring sugar from the bloodstream and to store it in the liver and the muscle. And what happens is, in the presence of the steroids, you need higher levels of insulin to achieve this, and we refer to that as insulin resistance, needing to make higher levels. So to further evaluate this, we do oral glucose tolerance tests. And what the oral glucose tolerance test entails is that the child is given a drink that has a certain amount of carbohydrates in it, and then at certain times afterwards, insulin and blood sugar are measured. And this is all done through an IV that's inserted in the child, so they only get stuck once. Other tests that are measured are hemoglobin A1C, which is a screening test for diabetes, and what we frequently find is that this test is normal. And we also do a lipid panel to look at triglycerides and LDL cholesterol. The primary means of management is diet, and I really want to stress this. And Jennifer Hall, our nutritionist, will go into this in more detail. And so we recommend reducing the carbohydrates in the diet, and we also recommend a low glycemic index diet. And what the glycemic index refers to is that it refers to the rise in blood sugar after eating certain foods. So the foods here at the bottom of the pyramid are low glycemic index and have less of a rise in blood sugar. And higher up here, we see high glycemic index. So after eating those foods, there's a more increased blood sugar. And so this just summarizes that mainstay for treatment for weight gain, elevated triglycerides, insulin resistance, instituting the dietary changes that I just mentioned. The elevated triglycerides, we also recommend supplementing with omega-3 fatty acids. And the insulin resistance can be treated with metformin to make the body more sensitive to the insulin. We recommend that the metformin be taken after a meal to prevent the gastrointestinal side effects, which are commonly abdominal pain and diarrhea. We also recommend a multivitamin because it can cause vitamin B12 deficiency. And then lastly, it can cause an acidosis in the bloodstream. So if the child has any vomiting, we recommend holding the metformin until that vomiting illness resolves. So next I'm going to discuss growth failure. So growth hormone is produced in the pituitary gland, and the growth hormone then stimulates the liver to make insulin growth factor 1, otherwise known as IGF-1. And it's a combination of both growth hormone and the IGF-1 that acts on bone to cause growth. But in the presence of the prescribed steroids, what happens is that in some instances, it causes growth hormone deficiency so that the pituitary gland does not make adequate growth hormone. In addition, the steroids also have a direct impact on bone that prevent growth independently of the growth hormone. And then lastly, it can also cause resistance to the IGF-1. So again, meaning that the IGF-1 does not work effectively on the bone for growth. So the assessment for growth involves a growth hormone stimulation test. And an IV is inserted so that there's only one stick. And the child is given medication that stimulates the pituitary gland to make growth hormone. And then at select intervals after getting that medication, blood is drawn to measure growth hormone levels. We also commonly do bone ages, and the bone age is looking at the maturity of the growth plates, and all of these are the growth plates, and we typically find that the growth plates are several years younger than the child's actual age. Treatment with growth hormone is administered as a subcutaneous injection, so it doesn't go into the muscle, it's a more superficial layer of skin, and there's a lot of different devices on the market that are used to administer the growth hormone. The decision whether or not to treat with growth hormone should be individualized for each boy and their family. And then lastly, I'm going to discuss delayed puberty. So there's a common theme here that lots of these hormones are all regulated by that pituitary gland. And so puberty is also regulated by the pituitary gland, and it secretes these hormones here to stimulate the testicles to make testosterone and to grow. In some situations, the prescribed steroids will prevent this process from happening, will prevent the pituitary gland from secreting the hormones that turn on puberty at the level of the testicles. There are some boys who do go into spontaneous puberty, and we don't intervene. We allow the puberty to proceed on its own because, again, the testosterone is going to help with bone mineralization. The puberty does tend to take a little bit longer than boys who aren't on the steroids, but eventually they will fully masculinize, and many of them will have adult male levels of testosterone. Okay, oops. Actually, can you, yeah, thank you. That one, yeah, thanks. So we use a cutoff age of 14 to determine if puberty is delayed. And if it is delayed, we can try to jumpstart puberty with testosterone. And we use a low dose of testosterone given as a monthly injection. It is given into the muscle. And we do it for 6 months, and then we hold the testosterone and we reevaluate to see if puberty has started on its own. And it's a combination of blood work and an exam that helps us to determine whether puberty has started on its own. And if it looks like that there is spontaneous puberty, then we'll allow that to proceed without any treatment. In situations where it doesn't spontaneously happen, we then resume the testosterone and gradually increase the doses of testosterone to achieve full masculinization. Because we're giving testosterone, the testicles will remain small, but there will be other features of puberty: enlargement of the penis, deepening of the voice, increased body hair, and then if you see in this picture, you see changes in the structure of the facial bones to a more adult male appearance. And other benefits are improving body image and integrating with peers. Thank you for your time, and if you have any questions, please ask during the question and answer session.
So thank you for the opportunity to speak. I really appreciate it, Deborah and the rest of the team at CureDuchenne. I get the fun talk. I hope everybody had a good lunch and some good snacks. I always get to talk about the good stuff, and as everybody knows in clinic, this is something that I talk about on a fairly regular basis, so to me it's a pretty normal conversation to have. But for other people, sometimes it's a little uncomfortable, so we're going to be talking about poop. It's okay. Everybody does it, and it's all right. So first of all, we're going to talk about what constipation is and how it's defined. So constipation is defined by both the frequency and the consistency of stools. The general definition is if there are 3 or less bowel movements a week, or if the stools are hard and dry and difficult to pass. That second part can be a little tricky to determine in a younger child, so we kind of have to look for some behavioral issues there to see if that's a problem. And so other signs and symptoms of constipation would be extended time spent in the bathroom, and that's in the absence of any electronic devices that might be extending that time in the bathroom. Actual natural time. Avoidance of bowel movements, again, if they become unpleasant, painful, uncomfortable, a child is going to avoid that activity. Bleeding or straining with bowel movements, large caliber stools. I hear fairly frequently from families that, that they just clogged up the toilet at the hotel before we came to clinic today, that it's very common to have these large caliber stools, and that is also a constipated stool. And then in an older patient with Duchenne, abdominal pain or chest pain can be the sign or symptom of constipation. Sometimes that abdominal pain sort of progresses up into a chest pain. Chest pain can then lead to anxiety, which leads to shortness of breath, and actually then can mimic problems with the respiratory system or the heart. And so the patients present to the emergency room in respiratory distress, which has been mostly anxiety exacerbated by this constipation that they're having. And so really a bowel clean out is what they need as opposed to a cardiac or pulmonary workup. Causes of constipation, just in the general pediatric population, would be poor fruit and vegetable intake, poor fluid intake, excessive calcium intake. A lot of children who drink a lot of milk, an excessive amount of milk, or who eat a lot of cheese or take a lot of calcium supplements can have constipation related to that. Iron supplements are also known to be constipating. And then again, behavioral issues, stool withholding. Some of our patients may not necessarily be avoiding stooling because it's uncomfortable, but they just don't want to stop whatever activity is that they're doing to go and use the bathroom. So there are some strategies that we can use to try to address that issue. In the Duchenne population specifically, there are some additional issues that can contribute to constipation. Functional limitations, including limiting fluids throughout the day because of the logistical challenges of using a restroom when away from home. So a lot of our older patients, our patients who are in high school, who are less mobility, really do tend to self-limit their water intake throughout the day, which then just makes constipation that much worse. And similarly, not wanting to use the restroom to move their bowels when they're away from home because of the logistic challenges involved with transfers, not necessarily having the right people around they're comfortable doing that or assisting them with that. So they will limit how often they will go to the restroom when they're away from home. Again, decreased physical activity and limited mobility. But as far as how dystrophin affects the muscles in the gut, there's still not a lot of evidence. The available evidence from a patient with known gastric dysmotility did show decreased staining for the antibodies to the dystrophin protein, but that was in one available patient. And then there was one case series documented, delays in colonic transit time in a pediatric cohort that was in a one-center study. So again, sort of a snapshot of patients, but not enough to really draw a general conclusion. So constipation is diagnosed using a certain set of criteria. This actually comes from the Rome 3 diagnostic criteria, which came out in 2006. There was a new set of criteria, the Rome 4, came out in 2016. However, the criteria are the same. So they have to include 2 or more of the following for at least 25% of bowel movements. They have to be straining, lumpy or hard stools, a sensation of incomplete evacuation, sometimes needing assistance to move the bowels, or having less than 3 bowel movements per week. So you have to have at least 2 of those criteria to meet the functional constipation diagnosis. Loose stools are rarely present without the use of laxatives, except in the case of what's called spurious diarrhea, which is when you have a hard, dry ball of stool that's sort of sitting in the gut that isn't moving, and you continue to put food into your body, that continues to leak around that stool and can come out looking like loose stool or diarrhea, but the problem is actually the constipation that needs to be treated, not that they're having diarrhea. So isn't this a fun conversation, everybody? We having a good time? Good. Here is the Bristol stool chart. This is something that was also developed with the Rome criteria, and sort of gives you the spectrum of stool consistency, if you will. And what I hear a lot from our parents is they have little rabbit stools. They have these little rabbit pellets. That's type number 1. We're not looking for type number 1. Watery, completely nothing solid at all, would be type number 7. What we're really looking for is that nice type 4, sort of smooth, has some moisture to it, kind of like a snake or a tube or a sausage, all these fun things we can use to describe what it looks like. But that's what we're going for. That's the goal, is that nice sort of moist, soft, easy to pass stool that it comes out in one nice piece as opposed to little pieces of stool. How do we diagnose constipation? There's a few other ways in addition to the criteria that we've already talked about. An abdominal examination, so we can literally feel sometimes in the belly that there is a massive stool that tells us that that is there. We can also have a sensation of tenderness to palpation or a sensation of a full belly, or we can actually see a rather full belly on examination. We have had a couple of patients with significant constipation who had a pretty distended belly when we saw them in clinic. We also, as patients of Dr. Wong's and mine will know, we like to show you your x-rays that show you your stool if we do have a patient who is constipated. Although it's not sensitive enough to be the only diagnostic criteria, it is a helpful piece of information that we can share with families and actually gives you a visual image of the stool that's actually in the gut. And then parent and patient concern. We do want to hear whether or not you think this is an issue, but evidence has shown that it doesn't identify every patient who has constipation. So a lot of families don't feel like it's an issue, but then when we ask further, their child is only having a bowel movement maybe every other day or every third day, unless they use some treatment, give them some juice, do something to try to motivate them to have a bowel movement. So that is definitely an important piece, and we want to hear from you if that's an issue, but it is not sensitive enough that it's going to pick up every patient. So how do we treat it? This is a slide that I borrowed from Brumbaugh and colleagues that was just published in Pediatrics last month that talks about screening for constipation and the more complicated version of that, which is fecal impaction. So we're going to talk about those treatment strategies in just a second. First way to treat constipation, drink more water. Again, I know this is a challenge for a lot of patients, and so finding ways that we can work fluid into their day in a way that makes them comfortable when they're away from home is a constant challenge. We're constantly learning from our patients what works for them in order to get more fluid in and trying to share that with other people. But a nice sort of rule of thumb is that you should drink 1 ounce of fluid, preferably water, for every pound of body weight, up to 100 ounces per day. And again, water is the healthiest option. You can add things to it. If your child won't drink plain water, you can add sugar-free flavoring to that. You can add fruit to flavor it, peppermint, things like that that can make children accept water better, making it nice and ice cold, especially on a hot summer day. But especially if you're looking for over-the-counter products that are sugar-free waters, you want to make sure that they don't have a lot of salt in them. Sodium is something that they can have a lot of, so you really want to just make sure, even if it's calorie-free, that the sodium level is good. And watch out for things that actually say water in the title. There's a couple of products out there that say that they're waters, but if you look at the label, they actually have a lot of sugar in them. So just want to make sure that you're picking something that is as sugar-free or calorie-free as possible for the reasons that we've already talked about as far as weight gain. Dietary changes, limiting dairy. We already talked about that just a little bit, but limiting dairy to 3 servings per day unless you're instructed otherwise. If your calcium is completely inadequate, your child doesn't really take dairy products, then of course we would recommend a supplement to make sure that your levels are adequate for bone health. But as a rule, we want to try to limit dairy to 3 servings a day because the increased calcium can be constipating. And then increase fruit and vegetable intake. Again, most people in the planet would be benefited by eating more fruits and vegetables, especially little children. They just don't do a lot of that. They might be really good about eating fruit, but not very good at eating vegetables. So some of the fruits that I like to encourage people to give their children, especially if they're constipated, are fruits that start with P. Pears, plums, prunes, peaches, things like that. Any fruit that starts with P is probably going to lead to the poop. So you just want to keep that little phrase in mind, and that can help you pick out those right fruits that are going to help your child go to the restroom. Also, berries, raisins, things like that can be helpful. Fruits to avoid would be bananas, because they can contribute to constipation, and fresh apples can also make constipation worse. And then vegetables, again, increasing the intake of those. Peas, carrots, a lot of young children who won't eat a lot of other vegetables will eat carrots. And then the leafy greens, sweet potatoes, and almost any version of a bean is going to help promote bowel movements. Other dietary changes that we can make would be replacing white breads or processed foods with whole grain or whole wheat alternatives, and baking things with the skin on. Even if you're going to mash your potatoes, keeping the skin on them so that the children get used to that. They get the fiber, the benefit of the fiber from the diet. And then other ways to treat constipation would be behavior modification. So routine or scheduled toileting. So about 30 minutes after a meal is a really good time to do that. Just have your child sit on the toilet without any electronic devices. Books are okay, other activities are all right, but the electronics tend to prolong the process. But we want to make sure that we're giving the child the opportunity to move their bowels at a time when naturally their body would want to do that, which is about 30 minutes after a meal. And then using a positive reinforcement system to go with that. So every day you sit on the toilet, you get a sticker on a chart. If you actually have a bowel movement when you sit on the toilet, you get 2 stickers. When you get 20 stickers, you get to go do something fun, or you get to get a toy, or some sort of positive reinforcement so that the child sees that they're actually getting a benefit from this, and this activity that might not be very pleasant for them is getting them something positive in return. So giving them some sort of reward system for that, and then recognizing those avoidance behaviors, recognizing if your child is going into a corner and hiding when they have a bowel movement, or that they're not stopping their activity, that they don't want to keep with a routine. All of those things could be indicators that they're having a really hard time going to the bathroom and that we need to intervene. So how do we treat it? First thing that we need to realize is that the gut needs to be cleaned out and sort of start as empty as possible before maintenance is going to be very effective. So the medication that is recommended by the Journal of Pediatric Gastroenterology and Nutrition is Miralax. Miralax is also known as polyethylene glycol 3350. It is a large molecule, and it is known through research to stay in the gut. It is not supposed to travel outside of the GI tract and affect any other systems in the body. There have been families who have reported possible behavior changes, neurologic issues, other issues with the use of Miralax long term, and there is ongoing research, actually Children's Hospital of Philadelphia at the moment, looking to see if there is actual evidence that that's the case. But so far, it is still the main recommendation from the gastroenterology and nutrition journals. It is found to be the most effective medical treatment for functional constipation and is recommended to be first-line treatment, not just for maintenance, but also for bowel clean-out. So really is very important medication that's used to treat constipation. It works by drawing more water into the gut, so the stool is softened naturally. It's not causing increased squeeze of the muscles. It's not changing the makeup of the stool other than just to draw more water into it because, as Dr. Wong likes to say, constipated stool is dehydrated stool. So we want to try to get more water back in there, and this is one of the medications that does that. Other medications that can be used to treat constipation would be docusate sodium, which is also known as Colace, which you can buy over the counter. Similar medication to Miralax in that it is an osmotic. It draws more water into the gut and into the stool, but it also has a little bit of a surfactant that makes it just a little bit slipperier and allows a little bit easier passage of stool as well. And it can be used by itself, or you can use it in conjunction with Miralax if Miralax by itself is not effective. Probiotics are something that a lot of people are interested in trying. We are certainly open to that trial, but there is no evidence in a pediatric population that they work on their own to make a significant difference in constipation. Every study that's been done in probiotics in children has been in conjunction with another treatment. So they used Miralax, they used different lactulose, other surfactants or things that make it slippery to help with the stooling. So it has not actually been studied that there is evidence so far of just using probiotics on their own to treat constipation in children. But they're generally safe. They're available everywhere. If you are interested in adding that to your child's medications, then I do recommend talking to your pharmacist about what is available to you locally. They kind of tend to be different strains available in different areas of the country, and what you want is a probiotic that has the most possible different strains of bacteria and cultures in it, as opposed to a one strain product that might not be as effective for you. Glycerin suppositories are also useful for very young children or for less mobile, older patients, and those can help, again, make the stool slippery and help move it out, and can also be used in conjunction with the oral treatments with Miralax or Colace. And then stimulant laxatives are something that we try to use in moderation. Something that we don't encourage everyone to use because they can have some side effects, cramping, gas, bloating, things like that, and can cause long-term dependence with long-term use. So we want to use those only for short-term to help with bowel clean-out and possibly with the beginning of maintenance, and then we want to try to wean those off. But those medications work by just increasing the muscle contractions in the gut so that the contractions are happening more frequently and hopefully moving the stool through the gut a little faster. So really, just to wrap things up, a combination of therapy is the best thing that works. Dietary changes, medications, behavior management are all pieces of the puzzle of treating constipation in an effective way. And for our patients especially, establishing a healthy bowel pattern is really important as they're young children, because as they get older, they are going to have those functional issues that make constipation more likely to occur, as far as not wanting to drink away from home or not wanting to use the restroom away from home. So what we can do when they're very little to establish a really positive, healthy bowel pattern is going to be really helpful as they get older. And I think, unless anybody has to use the restroom, I think we're done.
My name is Jennifer Hall. I'm a dietitian that works with this awesome team. It's very nice to see so many familiar faces here today. And I'm going to talk as fast as I can, but make sure it makes sense to you all, because I have a lot of slides and I know we're already a little behind schedule. But I thought it was kind of funny as Courtney was finishing up. Here we are, we finish up poop, and now we're going to talk about what to eat. Yeah. Doesn't that sound good? What goes in must come out, right? We should have done the opposite. Yeah. All right. So no major disclosures. I'm laughing because I'm also a jazzercise instructor, so I wear things like this a lot. The key principles that I want to talk about with nutrition management of Duchenne are overnutrition and undernutrition. Overnutrition being excessive weight gain, and undernutrition being malnutrition. That's something that sort of creeps up more towards the end of the disease progression, where there might be some dysphagia, some difficulty being able to attain enough nutrition, and that might become problematic, and we may need to talk about tube feedings. I'm not going to get into that today. I'm going to strictly talk about oral feeding. Bone health has already been alluded to by my colleagues as something quite important, and good hydration, not just for managing fluid retention, but also for regularity, as we heard about. So let's talk a little bit about energy needs. Energy needs is just a fancy way of saying calorie needs, but it sounds a lot nicer. Children with Duchenne are going to have definitely lower calorie needs than a child without Duchenne's. 80%, they'll have about 80% compared to that of another child without Duchenne. When there is less mobility, we need to account for that as well. That may also then drop your calorie needs by about 10 to 30%. So if I have limited calories, I'm really looking to make everything count. And this kind of stuff is not off limits, but I'm looking at the quantity and the frequency of when it's happening. Dr. Wong is very liberal, and she allows for these kinds of things, and so do I. If you've met me in clinic, you know I'm pretty realistic, and I want you guys to still be able to have these types of things. I want your kids to be able to still have these things. These things still happen in life. So what I wanted to spend some time mainly on is talking about the effects of the medicine that we do use, which is the steroids, and how we can combat these issues of hunger, facial fullness, as we see here, the cushnioid, weight gain, decreased bone mineral density, as was discussed, insulin, and hyperlipidemias, where we end up with high triglycerides and high LDLs. So yes, those who are on steroids are going to need more calcium. And we can see here, these just happen to be the levels that we use. So if you are not on steroids, you're going to see me going through your dietary recalls and your supplements, and I'm adding everything up. But then if we're on steroids, I'm going to need more. I always like to look at the diet first and see if we can add more calcium in through food. I don't like pushing supplements. I don't like adding another pill on. I like people to get their nutrition from their food. Call me crazy, but that's how I believe it. And then we supplement as needed. And there can be too much calcium in the diet and the supplementation. So that's why I'm looking always at all of the supplements that you're taking. As far as hypertriglycerides and LDL, the main treatment that dietitians use is we look at the excessive refined carbohydrates. So this is like sugar, okay? We do look at adding some omegas or boosting it via the diet. So that's something that we can go through together. More soluble fiber actually helps high triglycerides and keeping the diet overall around 30% of your total calories. LDL, what I'm going to be looking at is the sat fat and the trans fats. Trans fats you hear a lot about in the news. These are your hydrogenated or partially hydrogenated oils. Saturated fat you're going to find in full fat animal products. So that's dairy, fatty meats, things like that. I just threw a bunch of my favorites because I often will hear peanut butter is a very common source of hydrogenated oils. Even these ones are like Jiffy Natural, that whole choosy moms choose Jif. No, they don't. They choose just peanuts. That's really all I want to see on the ingredient list. I don't want to see any salt. I don't want to see any sugar. No palm kernel oil, which is what a lot of the peanut butters will have in them. You just want freshly churned peanut butter. I just have a thing about the peanut butter. So moving on. Facial fullness. So how we deal with that is we look at the sodium in the diet and we pump up the fluids, and long and behold, that fluid, the fullness will come down a lot in their face. We tend to keep it under 1,500 milligrams. This is not a low sodium diet. This is according to the My Plate guidelines. So I'm looking at, are you cooking with it? Is it at the table? The bigger sources I find for kids are going to be in foods, fast food especially, eating out. I'm going to be asking a lot of those questions. I like to hear what the style of eating is with your family. Let's see, snack foods for sure, processed foods, salty things like pickles and olives, of course. So I'm talking to my families about using other ways to increase flavor, switching to unsalted or lower salt options. Those are the kind of things that we talk about together and try. We just try them out. Fluids, again, I like to give it in sort of an ounce goal. If we're at 40 ounces and I can calculate that the child really needs more, we might try to aim for 60. I may not just make these huge jumps. There's lots of ways to make it more palatable. Some people are not comfortable using the artificial sweeteners, so I do steer them towards ways. This is a new line of dehydrated lemon juice. Some of them do contain artificial sweetener, but some of them do not. Otherwise, I'm having people do infused waters. This is just some of the modes that I've been using, or I should say your sons have been teaching me how to get hydration in and make it more of a priority, whether it be a different kind of a cup, vest, or an app, to remind themselves to drink. And I can definitely echo Courtney's sentiment about the toileting issues. I hear a lot of the kids saying, I just don't want to drink, or we have strategies of how to drink around their classes and their ability to get toileted and get to the bathroom. So you already heard a little bit about this, but how we address the weight gain and the insulin resistance is going to be through the glycemic index. Diet. So this is going to focus on the type of the carbohydrates. We also like to kind of add an extra step, and we look at limiting the total carbohydrate as well. It's not a low carb diet, it's just more moderate. So that's looking at the amount of carbs, okay? I will say that in general, like the DRI and the dietary guidelines, their carbohydrate recommendation is like 45 to 60%. So it is less, but it's not technically low. So what is it? So we're looking at the type of food. All these foods are still included in our plan. Okay, we still eat all regular foods here. You'll notice that meats and eggs, some of you, which is incredibly popular, I'm finding more and more, the parents are coming in already following a low carb, no carb, or they're familiar themselves by doing this reduced glycemic index diet. So that makes it very helpful for me when we start talking about these things. Ooh, good gravy. Can you help me out? Sorry about that. Thank you. Did you like how when I cursed, it was good gravy? I have another one. Geez Louise with extra cream cheese. All right, I'm going to stop. Okay, glycemic index. So this is just talking about how high that blood sugar is going to rise when you eat certain foods. We don't want this to be happening. I call this the aggressive roller coaster. I want to go on the kiddie roller coaster. So you can kind of see over here there's a parallel to what those types of foods are. What we do is we break that down a little bit for you. We make it into a stoplight diet. So the red foods are going to be foods that are going to increase your blood sugar the highest. These are going to be things that we're going to use a little bit more cautionary. Maybe we're going to have 7 of them a week, maybe up to 2 of them a day. We're going to include some of these, but the base of the diet is going to be green, okay? Low glycemic index foods, foods that are not going to pump our blood sugar up, making the insulin have to hypersecrete and promote more fat storage and all sorts of other things that we don't want happening. So you can go online and find all sorts of little categories of these. And this just kind of gives you an example of how we would be making switch. So things like white rice, soda, highly processed foods oftentimes are really going to be in that high GI category, and we're moving over. So instead of juice, we're doing whole fruit. We're doing whole grain bread, those kinds of positive changes. And this just shows you again another example. So the goal, again, is just to replace a lot of those high GI foods with more of the low GI foods. The other way to help maintain more of a stable blood sugar is to eat regularly. I don't like long gaps in between people's eating. I want everybody to be eating about every 2 to 3 hours to maintain steady levels of blood sugar. And I definitely am including grains, so this is not low carb. I want them to be whole grains. So you can see how you can do a little food combination here. And this is all gibberish, right? I mean, this is like blah, 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 blah. You need the real deal. So we'll get to the pictures. But I will say this, as far as, again, choosing foods that are going to have a lower glycemic index, the high ones are all this kind of stuff. So we do actually talk about the fact of looking at how much added sugar is put into foods. This is a really hot topic right now. Next year, at some point, they keep kind of pushing it out. You're going to be actually able to see how much added sugar is in a product. So, for example, certain things are going to have natural sugars in them. A cup of milk will have 12 grams of carbohydrate for 8 ounces. Yogurt, for example, is going to have naturally occurring sugar in that. But then they add the white stuff. And that's what's tricky, because you can't currently tell how much of that, because it's all listed under sugar. So you used to have to go over to the ingredient list and everything is listed by weight. So you'd have to see if it was in one of the top 5 contenders, and then you could tell, yeah, this product is probably mainly made out of sugar. But we look for 25 grams or under, and that's the American Heart Association, and that's my plate. I love this one, right? Who grew up doing that? Raise your hand. Yeah. But these are usually my big contenders. Yogurt, weird things that you wouldn't think of, like ketchup or barbecue sauce. All of those Skippy Jif Peter Pans, even the natural ones, quote unquote, they've got sugar in them. So the plate method is something that is pretty familiar. You've heard of My Plate. This is sort of just another take on it. And this works great if you're having, a very isolated protein, grain, and vegetables. So what happens when you have a mixed dish? Well, I think you can kind of get where I'm going with this. I want it to be mainly non-starchy vegetables. For those that are really struggling with feeling full and satisfied from their meals, what I usually advise, I hope this is going to work, is do 2 cooked non-starchy vegetables, half the plate, salad on the side, fruit for dessert, and protein-rich drink like milk. That will satiate you. And if you're still hungry, more non-starchy vegetables and more protein. Protein will have a delayed gastric emptying effect. So between the fiber and the protein, that will help to satiate you. The other part of this, sometimes when I talk to families, is the pace of the eating and where the eating is happening. Are there distractions? So are they hearing the message correctly, or are they chowing down and asking for seconds after 5 minutes? So those are some things that I do go through with families. These are the starchy vegetables. So just want to take a, right here, people always kind of think this is going to be just like rice and pasta. No, that's going to be peas, corn, potatoes, and winter squash as well, because it is extra starchy. So I do want you to keep that in mind. But otherwise, this is going to become your best friend, this group right here. So as far as portions are concerned, I like to just keep it simple. I don't like people to have to feel they have to measure food or anything silly like that. If you just go by your hand of the child, and that can be the same at 5 years old or 15 years old, that will help give you a guide of how much is appropriate for your body. And I know this is not news to many people, but it can be very helpful. And I really do take the kids' hands out and show them, and I have them make a fist, and I put it on their plate, the plate that you use at home, so they can understand this is how much it should be taking up. You may need to switch to smaller plates. And yes, they do sell plates that have the picturing of the sections of the food, like vegetables, grain, protein. If you wanted to do that, you can order those online. The portion that I'm usually most focused on is the carbs right here, the starches. And like I said, if the person is not satiated, I usually will suggest another serving of protein. This is going to be heart healthy, right? And yeah, I was going to say something else about it, but that was it. So again, just looking here. When do we start looking at modifying the diet? Do we wait for them to go on steroids? No. This is from the get-go. As long as you're willing to be open to discuss the diet, I like to start working with the families right away, and Dr. Wong feels that way as well. This is good for the whole family. Did I suggest anything wacky today that you feel that you wouldn't be good for anybody in your family? No, I don't think so. It's a lot easier when they're 5 versus 12 to do these things. So the sooner we can start to do this, it becomes more custom. And, it's very hard when they come to me already with there's thresholds associated with sugar and salt intake, flavoring. So if they're consuming a lot of that, it's very hard to then backtrack. You have to train the taste buds down, and that can be challenging. Early nutrition intervention. Again, this is just me starting to look at what's going on in the household. Are there regular meals? What's the snack situation? We talk about eating out, right? Fast food, takeout, all that good stuff. And there's sometimes there can be some struggles around this, that parents are like, I'm buying the food and I can't force them to eat it, and why won't they eat it? And we go through that, and that's a common division of feeding responsibility. That's Ellen Satter. I oftentimes will hear in the beginning, my kid doesn't eat many vegetables. What do we do there? So we start from that standpoint. Or a lot of times I'll hear that they're better with their fruits than they are with their vegetables. So we'll talk about strategies in order to increase their investment, and foods that or veggies that might be more palatable for them. And I really try to work with the child to see where they're at in the family. This is a really big one for me, is you've got to be in tune with your body. So meals are at the table, food and family only. Call me old-fashioned. So in summary, these are the big things that I'm looking at. Smart carbs, those that have low glycemic index. Whole grains, watching our sodium intake. The fruits and the vegetables and these grains alone will contribute to the fiber. So that'll help with our regularity and our satiety, blood sugar, all sorts of good stuff. Lean, heart-healthy proteins and fats. I didn't get into it, but Dr. Wong would probably be upset if I didn't mention it. She likes you to have a protein-rich breakfast. No white, refined, sugary stuff. She doesn't like that stuff. So That's something we usually do go through in our, that could be, and I'll just give you a couple of examples of that. That could be a smoothie made with low-fat milk, yogurt, vegetables, greens. It could be oatmeal with nuts in it. It could be scrambled eggs with veggies. You get the idea. Adequate calcium and adequate fluids. So I hope this was a reinforcement for those of you who I've met. Maybe for those of you who I haven't met, this is familiar to you, or you've gotten some ideas of ways to implement some of our guidelines for you and your family. So thank you.
Hi, so for those of you who don't know me, I'm Mike. I'm a physical therapist here in clinic with Dr. Wong. And we're going to take a few minutes to talk about equipment today. It's a really big topic, and many of you know we can talk about it for a half hour in clinic just on one piece of equipment. So today I'm going to try and talk and give a big, broad overview of it, and we're going to really focus on mobility equipment because I feel like that's the most nuanced piece of equipment and probably the piece of equipment that most families are having questions about and wanting to go through on. So we're going to briefly talk about all the different types of categories of equipment that we might recommend and that you might want to be using. And then again, we're going to talk about different options for mobility devices. We're going to discuss very briefly a broad overview of the process. And I want to preface that by saying the process is very different depending on what state you're in, what you have for funding sources, who you're working with as a vendor. So I'm really going to try and focus on some of the things that you can do as a parent or as a person with muscular dystrophy to try and make that process go as smooth as possible and make sure you're getting the right piece of equipment for yourself. We're going to briefly talk about funding and other types of resources, not only for funding and grants, but also just for figuring out what's out there and what's available for equipment. So where do we start? A lot of times we're in clinic and we decide that we're having a hard time getting through our day, and all of a sudden we need a piece of equipment. The first thing that I can recommend to any family is to be proactive. The last thing we want to do is be in a position where we're having a hard time getting through an entire day and we have a 6-month process to get a piece of equipment coming up ahead of us. It adds a lot of stress for you, and it adds a lot of stress for your family members and trying to get through your day in school. So we really want to get ahead of that. And a lot of times when we're in clinic and we're talking about a piece of equipment, we get a lot of reaction like, we're doing fine, we don't need that right now. But at some point, we're probably going to need those pieces of equipment. And you might need a few different pieces of equipment all at once, right? If walking's getting more difficult at school, then transfers in the bathroom might be more difficult. So there's a lot that goes into it, and we don't want you to get hit with all of that all at once. So spreading that out over some time and knowing it's going to take some time can take a little bit of the stress and anxiety out of that. We also want to work with a team. There's no one person that's an expert in all of the things that go into to getting a good piece of equipment, right? You have your neuromuscular team that's going to involve your physical therapist or an occupational therapist, a neurologist, perhaps a physiatrist. You're going to have a local vendor who's probably the expert on all the different types of, let's say, power chairs that are out there. And then you're also going to have someone who might be a representative of Permobile specifically, or Sunrise or Quickie, and they're going to know the very specific details of their chair. With the more complex piece of equipment, it can be really important to work with all of those different people to make sure that everyone's involved. But most importantly, you are important in that, right? We don't want to get a piece of equipment that our child isn't interested in, right? Or that you guys don't like the way it looks, or you're considering that this isn't just going to work in my home, right? I don't have that information because I might just see you in clinic. So it's really important for you to speak up and provide that information. So you want to be prepared. Think about, what do we have for funding sources? How is this equipment going to work in my house? Specifically with the larger base power chairs, it's not just getting the chair. It's, do I have ramp access to my home? Do I have a way to get back and forth to school with it? Are my doors wide enough? Is this going to fit under my sink? So it's not just that one piece of equipment, and it's a lot to digest. But the more that you can do on the front end before you go into your vendor or work with your PT, you'll be prepared to ask the right types of questions and determine what's going to work best for you. Do you have narrow hallways that you're going to be better off with a front wheel versus mid-wheel drive chair? It's important to ask those kind of questions because this piece of equipment is supposed to last for 5 years, right? So we'll get into some of that stuff a little bit. And then trialing the piece of equipment. I find a lot of families might have issues where they go in and they try a piece of equipment that's maybe not the exact equipment that they're going to get. For instance, if you try power assist wheels on an adult-sized chair, they may say, well, once we get into a pediatric chair, that might fit better and it'll work better. But maybe it wasn't the fact that the chair was too big or the frame was not the right size. Maybe it's just that that piece of equipment doesn't work well for you. So I think the important thing is to trial the exact piece of equipment that you're going to be getting and going to be bringing home, especially for standers. I know a lot of times you might get up in the stander and use it for 3 minutes or something like that. But that's not how we're going to be using it at home. So we want to trial the equipment over different terrains. We want to drive it in different scenarios, and we want to use that piece of equipment like we would at home to make sure that it's the right type for us. Getting those things done at the evaluation can be quite time consuming, but when we're thinking about using this piece of equipment for a long period of time, I think it's definitely worth it. And then ask questions. Again, your vendor, your PT, your physiatrist might know a lot about a specific piece of equipment. They might have worked with a lot of other patients with muscular dystrophy and have some idea about what to expect. But you know what's going to work best in your home, right? You know what your daily routine is. And if something doesn't seem like it's going to fit well into your life, you need to bring that up because everything's really individual and it's all a personal choice. Our job here is to give you the information about what's available and help you navigate that process. But ultimately, you guys are responsible for figuring out what's going to work best for you. And be proactive. I can't stress it enough. That's just, I think, with any piece of equipment, trying to get ahead of it. So when I think about equipment, I think about kind of 4 broad topics or categories. The first is orthotics. So some of those might be used for positioning to maintain range of motion. Others might be used during the day to provide support, arch support, decrease pain. There's a lot of functions of those. Mobility. So there are a lot of different options as far as passive mobility, meaning that you're pushed in it. Active, something you may push yourself. Power assist, where you push but you get a little bit of help. And then power chairs. Other types of equipment we want, I would lump into kind of home and ADL type stuff, right? So we have lifts that you might be using at home, bathroom equipment, ramps, beds, things like that. There is a lot of information in there and a lot of equipment that's specific to your home setup. Unfortunately, due to time, we probably don't have a lot to get into or a lot of time to get into that. So I'm really going to focus on the mobility aspect. And then other. So I lump in other as things that are more therapeutic, that we're trying to get a benefit out of, like standards for weight bearing and positioning, or assistive technology that you might be using at school to voice to text software, things like that, and also arm supports. So a lot of work has been done to improve the orthotic supports and some of the robotics to help with upper extremity function over the years, and a lot of that is getting better every year. So just know that there are technologies out there that can help with some of those things. So I think the first piece of equipment that a lot of families end up using is a stroller. And those I feel like are used because it's a little bit of an easier transition. They're available in a lot of different places. And a lot of families prefer these because they're kind of non-medical, right? So it might be a little bit easier socially to be using them. And I think that's great, and that's something important to consider. They're lightweight, they're folding. There are a couple different options. So you can either get a medical stroller that might be a little more expensive. It's going to provide some more support. Or there are some kind of over-the-counter or just commercially available strollers where the weight limits might even go up to 65 pounds and stuff like that. We always try to be cautious about using insurance fundings for things that are non-custom or non-medical. And again, when we're going to get back to what's called this 5-year reasonable use, which is a Medicare guideline that has sort of been adapted by a lot of insurance companies. And their expectation is that if you get a piece of equipment covered by insurance, that's going to last you for 5 years. Now, I'm not saying we can't get around that, but then the burden comes on us to prove that there's been a substantial change that warrants us to have another piece of equipment paid through insurance. So I just kind of want to use that context when everyone's thinking about equipment, as strollers can be expensive, but maybe not as expensive as some of our more custom medical devices. And then we have custom pediatric chairs. They can provide a lot more support and positioning than some of our strollers. They are more medical. They're often heavier. But the nice thing about them is that you can grow them a little bit. We can add supports if we need to on them. They're often something justifiable by insurance. And I just want to touch on a couple things that you might want to consider if you're looking at a chair. Lightweight folding frames, because the whole point is for us to be able to use them in public, right? So if we have a rigid frame chair, I don't know what kind of car you have, but it'd be great to have a folding one and be able to put it in the trunk, right? Swing away footrests. It's pretty difficult sometimes for kids to be able to transfer in and out of a chair if they have these two big bulky footrests right in front of them. And then push handles, because even with a chair, a lot of kids are using these when they're going to Disneyland for the day, or you have a full day field trip. And we're not necessarily intending them to be a full day use thing. And that's one of the other big important things about getting equipment is we want to be proactive, but we're not necessarily saying that we want you to use this chair all day long. We want this as a backup when we're going to do field trips, and to really kind of help your child be able to participate in the full field trip without having fatigue or having difficulty getting around. And then there are a lot of add-ons that I'm going to touch on briefly here on the next slide. They add a little bit of weight. They can add some cost to the chair. And then that comes along with insurance and appeals and all those other things. I don't know that any one piece of power assist or add-on to a chair has been perfect for everyone's setting. I think it's really important to consider what type of terrain we're going to use it on and when we're going to use it and how we're going to use it. But here's just a little bit of information about what's out there. So the first one here, and there's a few different brands of them, are power assist wheels. So power assist wheels basically work similar to a manual chair, but let's say I push that chair and it would go 10 feet. With the power assist, that same push is going to bring me 40 feet. Now that seems really helpful and sounds like you'd be able to get through your day with that, but a lot of times we're hearing that there's difficulty getting up a ramp, or by the end of the day my arms are too tired even to get where I want to with my power assist wheels. They can be quite expensive and they can be quite heavy. So they do add a lot of weight to the chair, so that's another thing to consider. Anywhere from 17 to 20 pounds per set. Now there is also something called a smart drive, which is kind of new. Great thing about that is that you don't need to push. The tricky thing about that, and depending on your child's age, maturity level, it takes a little bit of coordination. So there's a wristwatch, you have to double click and the chair goes. And then you can steer by breaking the hands. But you also need to actively stop it. So unlike a joystick drive chair where your child will let go and the chair stops, this is going to keep going. So we really need to be cautious about where they're using it for their safety, for other kids' safety, and especially in an elementary school. And then additionally, it's an add-on to the chair frame there. So you got to think about where am I going to use it. It's probably not going to work great over grass or over sand or over gravel. But if you're on a tile floor or a not too thick carpet, that can be really helpful. The other thing is an e-fix, which quite honestly, I haven't had a lot of people use. It is an add-on joystick drive to power assist chairs. Some of the feedback I've heard is that there's not a lot of customizable options with the joystick and the handle there. Some issues potentially with the durability and the wiring and things like that. Again, it's a piece of equipment that's out there. And this is why I really want you to work with a full team, because vendors are probably going to be more familiar exactly with what's going on with that equipment. And your PT is going to have some input about what things you might want in the next 5 years. And then you're going to know what's going to work best in your home setup. Another option for non-customized power mobility are folding power chairs and scooters. Scooters have come a long way in a short time. We used to just have the really old big scooters that didn't fit anyone, and we had a 7 or 8 year old child trying to drive around in a scooter with their arms way out in front and their feet hanging and their hips way out to the side. Things have gotten a lot better with them and they're more pediatric friendly. They still don't offer individual customization, and they still don't offer a lot of like hip support or great positioning. The other thing to consider with them is arms up the whole day long. Sometimes I've heard people have difficulty with their arms fatiguing. So when you're getting a piece of equipment like this, you just want to consider how and when you're going to use it. I'm not saying don't get it. Actually, they work really well for a lot of families. you just may want to consider how often you're going to use it during the day, and if you need something more customized or something like this. And then the joystick drive chairs, again, non-customizable, maybe a little bit of a higher price point, but also can be very helpful for that folding or travel. I know a lot of families don't want to put their primary kind of joystick drive chair on a plane when they're traveling, worry about breaking and things like that, which I think are very real concerns. And something like this might be able to provide that independence when you're on a short trip. It's just not going to provide the level of support and customization that a more joystick drive chair would get. And then again, the other consideration, again, and I hate going back to insurance again, but it's so important, is if we put something like this through insurance, then we need to say they need a full power chair for X, Y, and Z reasons, right? And they're going to say, well, we just got a joystick drive chair. So we really have to be cautious and consider about what we're going to be using and what we're going to be needing moving forward. And then this is the process that I think is probably the most complex that our families go through with equipment. There are a lot of options out there for power chairs, and there are a lot of functions on power chairs. You're really going to want to work with someone local for this. A lot of times you'll need modifications to the back or laterals added on, or maybe it needs repairs or maintenance. And it's really difficult if you have to drive 3.5 hours to go get that stuff done. So you want to consider a local vendor. You also really want to make sure that that person is in network. You want to make sure that your local PT is an in-network provider. The last thing you want to do is go to an appointment and then find out, oh gosh, we did this entire evaluation, but this vendor is out of network and my insurance won't cover it. Because then we kind of have to start the process all over. So equipment vendors are people who help with the evaluation about what's out there for equipment. They work with a lot of different brands of equipment, and then they can help us with the submission to insurance, delivery, assembly, maintenance. So they're kind of one of your primary contacts or point person for a lot of the equipment stuff, along with your local PT. And again, the process can take a lot of time. Even when the process goes pretty smoothly, we're looking at 3-6 months. I've seen people take up to a year. And then depending on appeals and what other items you want to get in that chair, it can be a quite lengthy process. So when we talk in clinic and we want to start this process, we know that we may see you in clinic and you might not even get an appointment for 3 months with a local vendor and a PT or an OT. And then the process could be another several months or more beyond that. And we really want to make sure that we get everything that you might possibly need over the next 5 years. So we have to consider, are you transitioning from elementary to middle school or middle school to high school in the next 5 years? Are you moving or going to a new house or off to college? What type of things are you going to need in your chair? And then the more stuff that we add, the more that we need to justify. So that can mean more and more back and forth with insurance companies, and that's kind of where the process can be a little lengthy. So we just want to be prepared and be proactive about it. A couple highlights of things that I think are pretty important to get in a chair would be tilt and recline, seat elevator, and elevating leg rests. I think a lot of our guys are using those and finding them very important throughout their day. And I really want to encourage you to have all of you guys use those things. So a lot of times we also get recline, or we get elevating leg rest and we don't use it. I had a kid come into clinic just a couple weeks ago, and for the first time, I think, in the last 4 years or whatever that I've been working, he went full back, we needed to adjust him, he went full back recline, shifted himself, got comfortable, said, I got it, I'm all set. No one likes to go to recline. I just did it in one of the chairs and it's kind of scary, I get it. It's uncomfortable, you're like, is this thing gonna tip? I haven't heard of one tipping yet. So when you go try those with chairs, go all the way back and recline, get used to it. Get comfortable using it. And again, if we get these pieces of equipment and start using them before we absolutely have to have them, then you can start to get more comfortable with driving them. You can get more comfortable using the seat elevator. You can get more comfortable using the recline before it becomes something that's really necessary for you to get through your day. So again, the process is very different depending on where you are and who you're working with. But I just wanted to give you a little bit of an overview of what it could be. I know that you may only see a little bits and pieces of it, but here, just in a very high level, we already have 5 steps, right? We have identifying, the referral, evaluation with the vendor, going through the documentation. And I will tell you, depending on the insurance company, the documentation can be very, very specific. It can be specific in the order that they do the documentation. For instance, the face-to-face with a physician needs to be done before the prescription. And all of those things are very specific to your insurance and your vendor and your setup in your state and your funding options. So funding. Again, many types of insurance. The bulk of private insurance or commercial insurances are based off some of the Medicare guidelines as far as DME goes. So that 5-year reasonable use has been adopted to a lot of different insurances. I'm not saying all of them, but working in a clinic where we see patients from a lot of different states and a lot of different backgrounds, we kind of go by this rule because it's the safest and the most, probably the most restrictive of the guidelines that we're going to work with. So again, really important to find an in-network provider. You may want to reach out to your insurance company beforehand and figure out who's going to be available for you. Consider what's going to go on in the next 5 years that you might want to use it for and what environments you're going to use it in so that when you go into that equipment evaluation, you're prepared. And then what do we do if insurance denies? Well, you have a lot of options as a person who's trying to get DME. You can have an appeal process where we can request more information from either your doctor or neuromuscular team, and there's peer-to-peer options. And there are also kind of private funding or charity donations, grants, and stuff like that. And the last slide here that we're going to go over is just a couple options. When I started to put together a slide about the funding options available, I realized there was no way I could fit it all in one presentation. So there's 3 that I want to highlight. One is actually the CureDuchenne DME resource guide. Now, it can be a little bit difficult to stay up to date on everything that's out there, so I also say just Google stuff that you're looking for. But this is a really good place to start, and it goes through all the different DME that you might potentially want to use. And then MDA loaner closets are a great option if you have a short-term need or a short-term change to help get you through until you get something specific, customizable to you. And then I've been getting a lot of questions about what do we do for grants for funding for vans and things like that. I found this website that actually you can go by state and find vendors for accessible vans and lifts and then grant funding by each state. So I think that's another pretty good resource. With that, I think that we can move on towards questions, right?